Welcome to our roundtable. The 6 months results of the WAVE trial was just presented at the CIRSE 24, and we'll be reflecting on that. With me, I have a distinguished panel of internationally well-known experts in the subject matter. My name is Mahmoud Razavi. To my left is Dr. Robert Jones, Dr. Dhiraj Rajan, and Dr. Panos Kitru, who will be reflecting on this data and giving us their perspective. First, Dr. Jones, you were the co-PI of this study. Can you summarize for us the study design, what was done, and what the results look like?
Sure. So the WAVE study was set up to examine the efficacy and safety of Merit Medical's WRAPSODY device in treating the outflow stenosis in vascular access circuits. The headline findings are that 43 international centers recruited patients across 4 countries, including the USA, the UK, Canada, and Brazil. There were 2 cohorts to the study. 245 patients recruited to the fistula cohort, which was the randomized arm of the study, and 112 patients to the graft arm of the study, which was more of a registry. And the results of that are expected later this year. But in terms of what we have for the fistula cohort, 245 patients, as I say, randomized 1-to-1 to receive either a WRAPSODY device or angioplasty. The headline results of that are that target lesion primary patency at 6 months, which was one of the primary endpoints, was superior in the WRAPSODY group at 89.8%, which is excellent. The best result that we've seen for any comparable device. And also the access circuit primary patency was coming in at 6 months at 72.6%. So overall, some excellent results.
Those are obviously great results in the context of poor outcome of historic way of we've treated these patients, which is balloon angioplasty. Dr. Rajan, can you put that data in perspective for us?
So I'd like to highlight the fact that this is a randomized prospective study that traditionally within the dialysis population in terms of interventions performed, a lot of it's been retrospective studies. We've really seen an improvement in the quality of evidence, first of all. And this study being a randomized prospective study, again, highlights the advantages of doing these studies. We see a clear advantage with this device. I know you really can't compare studies exactly, but we're comparing to multiple randomized prospective studies. And this device clearly has a far superior outcome. And this is remarkably in comparison to how angioplasty has improved in other clinical trials. We have seen the numbers come up with angioplasty, but the stent graft clearly outperforms it. And when we look at the drug-eluting balloon studies, it also outperforms those devices. And we've seen that in the first-in-human study. We've seen it with the IDE study, and we'll hopefully see it as well in the registry study. And there are retrospective studies that are coming out now that actually are parallel in their findings with the IDE study. So really a tremendous finding.
Dr. Kitru, your thoughts on what was presented a couple of days ago at this meeting and what you have seen so far?
I think the 90% target lesion primary patency at 6 months as a result is phenomenal. And I think since this is the second randomized control trial for cover stents in fistulas, it further strengthens the perception, the idea we have that we can have an additional option, the cover stent, for fistulas as well. And also the ability to move into a more tailored therapy and have more option for different lesions. I think this is very important.
So obviously the data that we have seen numerically better than anything else we have seen in the past has to be explained by the performance characteristics of the device. And this device was designed to overcome the mechanisms of failure, whether it's negative remodeling, recoil, or tissue proliferation, to prevent all of those. One of the features that we have seen when we implant devices in this circuit and elsewhere is the so-called candy wrapper effect or edge stenosis. What are the features of this device that are designed to prevent that?
Well, as you said, edge stenosis is the Achilles heel of covered stents. So With WRAPSODY, the engineering process has been to try to overcome that process. So at the interface between the edge of the device and the normal adjacent vein, the new device, the WRAPSODY, has been engineered in such a way to have a scalloped edge, so a softened end row, so that force at the end of the stent, at the end of the device, where at the interface with the normal vein is less, with the intention of creating less edge stenosis. And it looks like that's coming through in the results of the trials that we're seeing.
In other words, less impact, less trauma, chronic trauma over time. Dr. Rajan, this is a multi-layer fabric on the device that each layer has its own function. Can you describe to us about the impermeable layer and why is that important?
So just to highlight what Rob said, or Dr. Jones said earlier, you've also echoed previous generations of devices are simply arterial devices put in another indication. This is the first device that's purpose specifically designed. This includes the middle layer, so it's a tri-layer design that addresses multiple issues that weren't addressed by prior designs. And the middle layer is an impermeable layer. So as we'll get to later on, this prevents migration of smooth muscle cells through the material, and it prevents intimal hyperplasia formation on the inside of the device, which is a failure mechanism for these devices, and this layer just prevents that from happening.
So given the data and the structure of the device, as Dr. Rajan mentioned, purposely built for this application, does that give you more confidence in using this device, the WRAPSODY endoprosthesis, as the primary treatment for stenosis in the outflow tract in patients with AV fistula?
So like Dr. Jones said, he talked about the Achilles heel. And if we're going to stick to the Greek mythology, we have this Sisyphean struggle with stenosis and wrist stenosis. And this data shows that not only for de novo, but also for stenotic lesions, you have a tremendous effect. So I was optimistic with the initial trials on fistulas, but this further strengthens my opinion that cover stents could potentially be a first option, even for fistulas on dedicated places, dedicated lesion sites. For example, we should exclude the cannulation zone in the case of WRAPSODY, because then you would exclude one of the main advantages being the middle layer.
That's a great point. That's a great point. The WAVE trial came on the heel of the first-in-man study that was published on 46 patients, which was a mixed bag of patients that included grafts and fistulas and central and peripheral stenoses. And that showed a 86% target lesion patency at 12 months, and the access circuit patency of almost 70%, which is actually quite high for both of those at 12 months in this patient population, unexpectedly so. Dr. Kichwa, you have one of the largest experiences in the world with this device, and you have used it in central veins, peripheral veins, and in various situations. Can you share a case with us using this device?
So first of all, I think this one, being able to treat central venous stenosis is one of the main advantages of this device, because it's the first time we have a device going up to 16 millimeters. And this is not only for treating a stenosis, but even in the case that you have a complication. So rarely do we have cover stents, and we didn't have before, that have an adequate size that they could treat a central venous stenosis. So this is the case I would share with you today. And this is about a central venous stenosis. What you can see in the slides and the video is that there was an access from the vascular access and from the femoral region. You can see this simultaneous injection where you can actually see the 99% stenosis that was negotiated. Every time this stenosis is gradually upsized and inflated from 8 to 10 to 12 millimeter high pressure balloons. And once we are ready, or in case we fear that there's going to be a rupture, we deploy the cover stent. In this case, it was a 14 millimeter WRAPSODY, and then we can post-dilate through the cover stent, which is much safer. And this is what we see in this case.
That's an excellent case example with excellent results, obviously, that one would expect using a device such as this. There is the WRAP registry that's ongoing that Dr. Rajan and Kichru, you guys are the co-PIs on it. And so, Dr. Rajan, can you tell us about the WRAP registry and the enrollment update?
The WRAP registry study is a prospective non-randomized study. It's being conducted in countries where the device is approved. These are purchased and then used. This follows real-world experience. If anything, it parallels what we saw with the first-in-human study. It includes ABGs, ABFs. It includes central lesions. We're looking at up to 40 to 50 centers. There's currently 31 that are enrolling. We're looking at 500 patients in this study. 309 have been enrolled to date, actually more than that at this point probably. That was the most recent number. About a third of those have completed 6-month follow-up. So the registry study is going to look specifically as primary endpoints, the target lesion primary patency at 6 months and safety outcomes at 30 days. There will be multiple ancillary outcomes. I won't go into those, but they parallel other studies. But if you want to really understand what the registry looks like, the first-in-human study kind of gives you an indication. Again, this is a global study. This is a post-market approval study. Patients are recruited based on IFU. It's not like the IDE study that had much more stringent criteria. The hope is that we get a better understanding of how this performs in real world, and I think the first-in-human study is an indication of what we'll actually see with the registry study as well.
So, Dr. Kichru, as the co-PI of this registry, how's the enrollment coming, and when can we expect that the study will be complete?
First of all, I think these registries that are real-world studies are as important as randomized studies. So I believe we will see some data, even preliminary, in the near future.
I want to thank the panel for participating in this roundtable and discussing the very exciting news